you, Tree. Yeah, just thought it would be good while we were waiting for David, firstly to say hello to you all. So many people we recognise, but also some new names. If you've not seen us here before, it's very good to see you and to meet you. And hopefully you'll soon get into the swing of it and fall into the pattern of connection with all the people here. So I thought it'd be worth saying a few words about the article we published in the Observer, because this group, in a way, was a part of it. It came from a number of places. If we went by looking back on the early narratives we'd written to say, well, do these stand up? Do these look any good? Now the world has moved on months from when they took place, and so much of it was right at the time and still right now, but the context was different. We needed to present it a little differently. And we'd had a number of conversations with some national figures in national politics, some people from local agencies, people from the World Health Organization, directors of public health, particularly public health professionals working on the ground, to say, well, what's happening and what needs to happen, and how might all this work? How might we respond in a better, safer way that meant we could avoid repeatedly going into lockdown and yo-yoing from one lockdown to another, coming in, going out, coming in, going out, because the uncertainty is awful. The constraints are not good. So what's needed? And we also have been testing these ideas with you over time. We've been hearing your comments. We've been finding the words that work, the words that don't. No words seem to work for everybody. There's always something that strikes a chord in one language or in one culture, but works a little differently in another. But we'd been sort of testing that, and we wanted to put across quite a number of quite simple ideas, I think, but that work together in a multi-layered approach. And we thought all these things are needed. It's not that you need to do one thing or another. It's not that we need to blame one group or another. It's not that if somebody else isn't doing anything, that means everything, we don't have to do our bit. And we came up really with things that I think you've probably heard David rehearse a few times with you. And they were these 7 things, if you recall. The first was, we said, this is primarily about people and what we all choose to do in our lives. Breaking chains of transmission has a big factor, which is about more people doing more of the right things more of the time, because they choose to, because we know what we need to do and we take responsibility for our element of it. So we have to engage with people everywhere and see people as part of the solution and not part of the problem. And we're quite, although at times it may be frustrating when people say things that seem silly or things that seem at odds with what's known, but we very much believe that most people are capable, bright, want to do the right things for their families, for themselves. And if they are, doing things that seem frustrating or seem a little odd, then we need to engage with them and respect them and try to understand where they're coming from and not demonize them. But most people, and probably most people, we don't give enough credit for this. Most people, most of the time, are being really, really sensible and doing really good things. So that was the first thing, people being at the heart of it and all of our individual behaviors. The next thing we said was, you've got to tell the story right. You've got to be clear and consistent and honest and truthful in your communication. And if something has to be so, then don't be apologetic about it. If we've got to do something, then we need to own that. And senior leaders owning the messages that they give really, really matters. Standing up, being accountable, and expressing honest vulnerability at times. There are things that we don't know. There are things that we have as yet to figure out. Many of those topics have circulated in our conversations over the past months as we try to explore them, because it's still in many respects quite new. But if we're not giving a consistent and a stable and a steady message, then people do get confused and do behave in a variety of ways that might not be the ones that were most helpful. The third thing we were talking about within it was this, David's often referred to it as a sort of honeycomb of community groups, because contrary to what some politicians may have said many years ago, there is such a thing in our view as society, that all our communities have all sorts of groups of people who meet together or who identify with each other, whether they're about sports groups or religious groups or children and young parents groups, older people. There are all sorts of different networks and connections. And if you connect those up, you've got a very active way of engaging with a very, very wide number of people in a way that is quite hard for a national government to do. One of the things we found from the trust surveys is people really, they really pay a lot of attention to what head teachers say, to what their local doctor, the general practitioner, the primary physician says. And if we can get good and steady messages to those groups of people, we can spread through the sort of community support networks that exist already patterns of behaviour and interaction that are really helpful. The thing that I think David keeps coming back to, in a way, it's sort of what he's been about most of his life, is that the public health professionals, this really is what they know how to do, and we need to trust them, and we need to value them, and we need to see them at the heart of what goes on. If we're talking about testing and tracing and cluster busting and all these sorts of things, it's people whose background is in public health who know how to organise to do this, and we need to back them to make that happen. And that means connecting them sometimes, because there won't be the resource in many countries that do it. It's often about mobilising large numbers of volunteers or different groups who may have been working on other things, but connecting them to that expertise, which is often very local. It's people who understand the particular geographies of the places that they work in. It's the people who understand the particular cultures, the different communities that exist there, and know how to find people and how to talk to people and how to connect to people and know what to do when they do find them. So the public health community, we said, were very much at the heart of it and needed to be recognised as such and given that space to operate, to use that expertise. The fifth thing that we brought into it was this idea of an integrated incident response team. And this is not, again, none of this is new. This is not a new thing from COVID. This is how many outbreaks have been dealt with over many years. But it's this sense of getting organised locally. Who are the people locally who have access to the local elements of the state, who connect to the business community? It's usually a local municipal or elected authority, and using that leadership to convene all the assets that are available to get things done. And we've seen great examples of that with university leaders setting up their own testing and tracing facilities. We've seen all sorts of things taking place at that sort of level. We've seen, for example, city leaders talking to the leaders of the hospitality sector, saying, well, okay, we know, or we think a lot of transmissions taking place in the nighttime community. How are we going to manage that? Because this is your guys' future as well as your current income. So the incident response team is not only running the place and it's convening the people in the place to do things, but also connecting to the national responses that are available, because there is a need for the sixth thing, which was the national response that says, there are some things that do need legislation. If we want to impose restrictions on people's movement, that's a serious thing to do. And if we want to enforce that, it needs to be properly legitimised. So there are things that national governments can do that more local levels of response find hard. One of which is making sure people are properly looked after financially, where you can, making sure food is supplied, making sure that there's that if a vaccine arrives, there is a delivery chain that can keep the cold chain intact. All those sorts of things are going to require a national response, and the national response needs to be organised in that way, but also to not see the local element as somehow subservient, to see it as a partner and as the people who really do understand what is needed in a place to get anything done. And then the final part of it really was this idea that, but you can't pick and choose. It's not that we only need a good national response. If we only had a good national response, everything would be all right. Or if only people were more responsible, or if only we just got the message right, it would all be fine. All these things interact with each other. And if any one of them isn't there, it sort of undermines the capability of the others to work. It's not that the others shouldn't do anything there, for one sake, well, it rests somewhere else. It's really important in any response that we've found that you spend so much time attending to relationships. We've found that in places where good and long established relationships exist between agencies, it's so much easier to get things done, because the senior people know each other, can pick up the phone and call each other, and they understand what the pressures are on each individual involved. Where you create new agencies to do that, it's really quite hard, because those relationships just don't exist, and you have to build them and you have to forge them over time. And it often ends up by beginning at sort of with maybe a regional response before you get to the national. And that's been true in so many other situations, in so many other outbreaks. It's really important that you attend and pay close attention to how do people connect to each other, because in the end, it's all people who are trying to get the same sort of things done. They will have different perspectives based on where they sit, the way they look at the problem, and only when you start to share those together does it begin to make sense as a whole. So that was what we published. You always write these things and try and chop the words around. You always look at it and say, oh, if only I'd had 1,200 words instead of 820 or whatever you're given. You always try and slip a few more in. And what we were trying to do was sort of weave together all of those things that we've been testing and sharing with you. So Twee, I think it's on the website, it's on the 4SD site. So if you'd like to have a look at that, do. And if you read it and you like it, hopefully you'll recognise some of the conversations that you've been in, some of the bits that some of you put it perhaps onto the LinkedIn group, and see a little bit perhaps of your authorship in this. Because when we say that people matter, it's about people. One of the things we believe in this is a good idea doesn't care who has it. A good idea is just a good idea. And so where we've got things from other people, we're really, really happy to sort of pass them on and share them in the hope that it makes sense to all. So there's what we've been up to on that. Have we got the links up there, Twee? Is that something that people can see?
We do. Yeah. We have the Guardian link up there, and just 1 second, I'll also put the link to the version that's on the 4SD website as well.
Good. So maybe if some of you have seen it, while we're just waiting for David to finish his last bit, if some of you have seen it, we'd be interested to know what you made of it. Does it work for you? Does it capture what we're trying to say? What more could we do? Rebecca, is that a hand up or is that a clap? I can't see from the...
I don't know. It's both. I love it. I'm extremely critical, as you all might know, and I really couldn't find anything wrong with it. And what I really liked about it is I think it's good forever. It's a forever document. It doesn't matter if COVID goes away, or if other pandemics come up, or if climate change continues. If we keep doing all those things, they're all good things. We need to keep, and that's the only way we're going to build resilience. The only totally minor thing with it that I thought might be a little misleading was the picture of the vaccine, but I understand it's for a certain audience. But I thought the text is fantastic. It just needs to be taught and disseminated for decades to come.
Thank you, Rebecca. And as always with these things, you're never quite sure the words that people publish, and you often don't get to choose the headline, and you very rarely get to choose the picture. But hey, we were very pleased that they put something up. But I think David is with us now. I'll say one last thing, David, before I hand back, which is to say to Rebecca, I think what you're saying about it being timeless matters, because COVID has exposed various things about the way that we live together, the way that we organise, And the things I think that are in that piece, I think you're right to say, are more than just for COVID. So, David. Why has
it gone mute? Well, but I've lost you, John. Oh, now you're back. Okay. To John, thank you for presenting the article, and thank you for being the brains who pulled together ideas that were expressed in these meetings into the initial structuring of it. And we then had, as John, I think, implied, a bit of an adventure trying to get it published, but we were lucky. And then we're watching it go to different places, particularly into the US, where this thinking is relevant, and also to some other parts of the world. I'd like to now welcome everybody, apologize like anything for being late, and I'd like to invite one or two people who I encouraged to join today, because I thought it was time that, as well as presenting to you about our Guardian article, we also took stock of something that we've been focusing on in these briefings since quite early on. And it's called long COVID or LOCO. It's recognized as now an absolutely distinct medical condition, and it has features to it. And I wanted to ask Robin Gorna initially, and then Robin has invited two other people to join us. So Robin, plus, if she doesn't mind, Clare, Rayner and Jake Suett, to take us into an understanding of where things are with long COVID. Because for me, this is a second massive reason why the kind of work that John and I referred to is so important. We need to help people avoid getting COVID if possible. And we need to go on focusing on what needs to be done for those who've got long COVID, again, through these honeycomb structures at community level and through well-organized health services. Robin, thank you for coming. I'd like to give you a bit of space now to just take us into your journey and what you've been doing since you last joined us some weeks ago on one of these briefings. To Robin.
Thank you, David. And it's lovely to see so many friends and almost family around the table, the virtual table. It does feel a bit like coming home. I joined you initially, I think 6 months ago, when I was struggling to breathe. And David introduced me to Professor Paul Gorna, who I think is the person who can be credited with first introducing the concept of long COVID. And it was a rather terrifying discovery as I sat with David and talked about what was going on in the acute phase of COVID, to hear that maybe I wouldn't get better within 10 days, as the NHS was telling me. And 6.5 months on, sadly, I am still living with COVID symptoms. The shortness of breath now comes on when I try and walk. And as Claire knows, I managed a full 5,000 steps earlier today, and that did get me a bit out of breath, but that's a huge improvement from even a couple of weeks ago when a 10-minute walk would have me floored. And the realities of living with long COVID is that it's a really erratic, unpredictable condition. And I know some of you from my professional work, and it's really strange having been around another pandemic at its initiation, the pandemic of AIDS, and to know that you can't know in the first 9 months of an epidemic what it's going to look like in the next couple of years. I think all of us hope that people recover from COVID slowly or quickly, but the truth is that we can't know. And the three of us, I'm really fortunate to be joined by two of my great new friends, Dr. Clare Rayner and Dr. Jake Suett. And I thought we'd bring a couple of fantastically medically trained people, because I'm not one of those, although I've been around the global health community for a while. And I wanted to pick up on 4 points, but I'm going to let Clare and Jake speak to these in more depth as well. So at the moment, I'm serving on the NHS Long COVID Task Force, as well as continuing to be involved with the Global Fund, where I'm one of the focal points on the technical review panel. but that sounds grander than actually what my energy allows. So I'm very erratic in terms of my workload, and certainly living with long COVID has given me a lot of pause to reflect on things that I've known professionally over the last 3 or 4 decades from the AIDS crisis. And I really love the article, John. I hadn't seen it before. Congratulations to you and David for that. And one thing I wanted to bounce off the back of that and mention is, as we're thinking about communication and information, one of the things I really invite all of you who are leaders in your space to do is to think about how we get the message out that COVID isn't just the weird flu or an inevitable quick death. I think that tragically still in a lot of public conversation, there's a real misunderstanding. It's something I know we've talked about before on these calls because I've been part of that, but I can't emphasize it enough. And living in the middle of the UK, watching this epidemic take off at such horrible pace all over again, I think there's a really deep misunderstanding. And many of the new friends I have, Jake, as you can see on the screen, is an awful lot younger than me. And some of our other friends with long COVID are in their 20s and even their teens. And these are people who for 6, 8, 9 months are battling with really serious conditions, some even confined to wheelchairs because simply of the symptoms of COVID. So I think it's a really important and urgent public health message to hear our experiences. I think I'm living with a very mild dose of long COVID compared to many I know. So that's number one point, is just to integrate our messages and our experiences. And I think that's coherent with what you have been talking about in that article, David and John. The second thing I want to emphasize is long COVID. I very cheekily in a message with David talked about living la vida loco, which is just cheers me up a little bit to think of it as loco. And I don't really speak Spanish, but I understand it means crazy. And those of you who know me will appreciate my weird sense of humor. Actually, within the community of people who are struggling with these symptoms, we're trying to push really hard for this to be understood as long COVID. There's a bit of a push here in the UK by some quarters, resisted by many others, to redefine this as post-COVID syndrome. And I'm going to just dwell on that momentarily, and I suspect Clare or Jake may wish to as well, because what I'm living with is not post anything. I'm still irritatingly ill on many days and frustrated by it. And I think there are clearly similarities with it for some people with post-viral fatigue. There are similarities with other conditions, but this does appear to be a unique and different set of symptoms that many of us are experiencing. So I think until we know more, and as you as public health and global health people know, we can't know more until we've lived with it for longer. Until we know more, we really urge you to stay with the terminology that we as people living with this condition have for it, which is long COVID. It may in time be that we call it a syndrome. It may in time be that we call it something entirely different. But for now, what we are experiencing is long COVID, a long tail presentation of COVID. And for those of you connected with WHO, I'm desperately trying to discover whether there is a guidelines process underway on long COVID, on the naming and definition and natural history of long COVID. There is a beginning to be a sprint in research in the UK, which hopefully in time will help us understand the various presentations of this condition, which, as I say, are different in different people, but we need to have an internationally agreed name for this, and we need to have an internationally agreed understanding of how it presents, because tragically, many people, and I've had great GPs, so I haven't experienced this, but many people have experienced gaslighting from their GPs, have experienced real ignorance and harmful attitudes. I spent a day in A&E, and the only thing I got from A&E was the experience to educate about 12 different doctors and healthcare workers about long COVID, but not a single one of them had ever heard of it. So what I'd then just like to do is say two final things, but hand over to you, Clare, and Jake, which is in the chat. I posted another article that came out on Sunday in The Guardian, and The Guardian's been doing a crackingly good job, as I think we all know. And they reported on the preliminary findings of about 251 of us who participate in the cover scan trial. They're looking to recruit more than that, but they've done an interim analysis. And I think the other two, I'm certainly a participant on that trial and have written about it as well. And what they're discovering is that we do have multi-organ damage. about 2/3 of us have damage to organs, and what we don't know is whether it's causative. So we don't know whether it's why we have long COVID or it's a consequence of long COVID. And the other thing which I find very striking about it is 66% of us have one organ damage and 25% multi-organ on this preliminary analysis. It's actually the heart, which is the organ most affected, not the lungs. In fact, the lungs appear to have very limited impact. But as you can tell, with something that is having that impact, it's not just a post-viral fatigue, as some people have been dismissed with. And I think the other thing that, again, Claire and Jake as doctors are much more able to talk about, but just to flag for us as a global health community, the impact on them as doctors, the impact on health services. And as we think about countries that struggle with weak health systems, it's not just about health professionals dying from COVID, although that is the absolute tragedy, but it's also about the hundreds and thousands of health professionals who are acquiring COVID in the course of their work and then cannot return to work safely. Claire's an occupational physician, so let me hand the floor to her as I hope a logical connection. Claire.
Hello, thank you so much, Robin, and thanks for having me here, everyone. I'll probably pick up on that last point first about the occupational aspects so I don't forget. I think, first of all, that I wanted to say, John, I loved what you said about your article and about connecting and collaborating with communities. Although as a consultant, I've worked in quite a hierarchical situation in the NHS. I left it long ago and I worked as an occupational physician in other organisations. And within our specialty, we're very much, we shift those sort of boundaries. But personally, I'm a collaborator. So within this long COVID journey, as we're calling it, one thing has led to another so much, and it's been strange but wonderful. So just a brief mention about the occupational aspects on healthcare staff. We know now studies done in Britain show that they're 3 times more likely to become infected. Long COVID in general, well, the prevalence of it has not been assessed or quantified, so we don't know how many people are involved in general. But what I do know is that Jake and I are part of a group of doctors with long COVID in the UK, and there are over 500 of us just now. So a lot of the learning has gone on amongst and between us. We will be the tip of the iceberg, but those people are off work for now 7 and 8 months because most people were infected in mid-March. Very sadly, we're now seeing new doctors and other healthcare staff come along with the infection. So I wrote early on in the pandemic about patterns of illness that I'd noticed. I think there was an issue with not recognising the very mild symptoms of COVID, and people were not isolating. So we've got to get a much clearer message out to people about what those initial very mild symptoms are. I recognised quite early on that there were some quite strange patterns. For many people, long COVID involves a very fluctuating course. Certainly the first part can be quite severe, but then you tend to get the impression of getting better and then you get worse again. And I'm sort of doing an up and down thing with my fingers to show those fluctuations. I've never had malaria, but it reminded me of teaching at medical school where they talked about disease, malaria, where you would get these periodic fevers that came every 3 or 4 days. And so in some people, you can get these sort of recurrences or relapses. But basically, there are huge numbers of people, I'm sure in every country, with very prolonged symptoms, and there is organ pathology. That is the main thing I want to get across. The cover scan thing that Robin's mentioned is one of the first studies to really identify this. And I think to say that there are 2/3 of people who have organ damage and 25% of people who've got more than one organ damage, it really reflects the message that Jake and I have been trying to get across for this length of time. I think those are probably the main things I want to say. Other than to agree with Robin, I have really very significant concerns about calling this post-COVID syndrome, because as Robin says, it's not post anything. In the majority of cases, people with long COVID haven't actually received assessment. They have not had adequate assessment of this organ damage, and that needs to happen for individuals. Yeah, I think those are my main things, and thank you for asking me to talk.
So thank you both, Robin and Claire. Jake, you've joined us as well. Would you like to go now?
Hello, thanks for having me. It's nice to meet you all. I'm just going to speak very quickly about this. Robin and Claire have done a good job of summarising, but there's a few key things I just want to get across. It's bad. I can tell you that. I can assure you it's bad. I'm 32. I was fit and well. I was going to the gym beforehand. I still get short of breath when I lie flat now. I'm a lot better than I was, but I would say my life has been changed over the last 8 months, and so it's really important. Second thing I would say is you will not be hearing from the sickest people. A few months ago I couldn't have had this conversation with you, and I do know that there are people, I'm in communication with nurses and colleagues who have not been able to speak publicly because they are so sick that they are literally bedbound. So always remember that you're seeing the tip of the iceberg, and the people that you're hearing from are potentially the ones that are more recovered. Whenever I've spoken about this, the main thing that I think summarizes the whole problem is uncertainty. If you think of this issue as just uncertainty embodied, we don't know how many people it affects. We don't understand the pathology. We've got clues now, so it's nice that there is this emerging evidence because there's something to point to, but it's clearly uncertain what the long-term effects are, and the underlying mechanisms are uncertain. So I think until we know more, uncertainty is the key word. There is a lot of good news coming out. So in the UK, we've got nice guidelines coming, we've got clinics coming, we've got £20 million of research funding. So I am hopeful that we will eventually get to grips more with this, but we have got to address this as a public health issue, and we really need to talk about it in conjunction with when we talk about deaths and so on. And it's just good to talk about civil society in general. As you said, it's really encouraging to me that there are now a few of us from around the world as community and civil society representatives on the ACT Accelerator with long COVID, for example. And so I'm speaking with colleagues from around the globe. And one of my main concerns is that we are starting to make some progress with clinics and research in the UK, but you know, I was lucky, I had some savings. If I didn't, there would be a welfare system. I do wonder how people are coping with this condition around the world, and where governments may not want to acknowledge that it's a problem. And I think the next stage is going to be us working together to help those people. You know, I cannot imagine how people who struggle to live on a day-to-day basis would survive with this for a long period of time. So I think we really just have to think about this as a global issue and keep the uncertainty at the top of our minds. Thanks for your time.
Robin, Jake and Claire, thank you very much for joining us and for really bringing us up to date on what's been going on. I listened to you and I'm just thinking of the magnitude of the challenge for millions of people in our world who, as a result of this virus, are now suddenly facing huge uncertainty about their ability to do some of the most basic things they need to do, to walk around, to do exercise, to think and work, to socialize. It's clearly an absolutely massive, I was going to say handicap, but that's a loaded word, but it is, in the absolute sense, something that gets in the way of your being able to live. And I think your courage of being prepared to stand up and talk about it is really special, because it's through your witness that others will be enabled to speak out. My concern, that I think all of you encapsulated in your words, is that there are an awful lot of people in our world who are not recovering quickly from their COVID, who are having long illness, but who are also unable to convince their families or their employers or their friends that they're actually very seriously affected. And so I think by your bravery, we're now enabled to focus on this. And I'd like all of us to be thinking, what can we do to raise awareness of this particular challenge in the different settings where we are working? Robin, did you want to say any remark before we go into the discussion phase?
No, I mean, thank you all, and thank you for the very warm and generous comments in the chat. That they mean a lot. I suppose there's one thing just to underscore, which is Jake and Clare are very modest. They both sit on the ACT Accelerator pillars. Jake for diagnostics, you may not be aware, but there are many challenges around diagnostics beyond perhaps the obvious, including that many of us with long COVID have unreliable results in terms of antibodies. So there's lots of technical challenges, and that's one of the many things that I know Jake and others are looking at. And Clare sits on the pillar related to therapeutics. And I think we're all thrilled that ACT Accelerator is up and running, but it's really important that, as a couple of people have mentioned in the chat, let's not lose sight of treatments. So, you know, that, and yet I haven't even had a physical check with a doctor in over 6 months, and I'm a fairly empowered patient. So this point about assessment and treatment is really critical. I think we understand why health systems are dealing with the spike and the pointy end of the problem of the acute phase. But as Clare has mentioned, there's a real challenge that those of us with persistent conditions are not being assessed and treated. And there seems to be a real lack of focus on the therapeutic question across the whole span of conditions. And as you say so eloquently, David, this, you know, we are the three of us in the fortunate situation of being educated, middle class, white Brits who can stand up and speak out with, you know, even when we experience difficulties as a consequence of our openness, it is nothing like the horror that friends and colleagues have in other countries. So I think part of our motivation, I can certainly say for myself, is to advance the agenda. And let's not write off people as if they've had COVID and they're fine. And this is not the reality for our world. And you all have voices in places that matter. So
thank you.
Yeah, thank you.
And you, everybody, Robin's been a really extraordinary activist for people whose lives have been turned upside down by HIV. And she has been at the center of efforts to bring people together so that they are able, through collective action, to make a change. And I remember Robin saying to me, we really need to apply the HIV experience to long COVID. And you've just shown us that. Jonathan Fitzsimons was asking a question. Jonathan, would you like to ask it? And I'll ask Clare to answer it.
Thank you, David. And Robin, Jake, Clare, thank you so much for sharing your experiences. I'm a family physician in Canada, and since March I've been running the COVID-19 Assessment Centre. I live in the largest county, the largest geographic county in Ontario, so we have a virtual assessment centre. So I was delighted to hear about the pillar number 5 of David and John's article about local solutions being so important. But my specific question that David mentioned was about treatments. You know, we've heard about the use, for example, of dexamethasone in hospitalised patients, particularly with moderate to severe symptoms. Has there been any use of any therapeutics or any attempts to trial that with patients with long COVID?
So,
No, none. Absolutely none. We've been battling incredibly hard to even get it recognised as a thing. So it is our feeling amongst the doctors with long COVIDs and other patients who are active with long COVIDs that we were just as ill as many people that were admitted. But we have simply received nothing. We're asking the questions, well, surely we would benefit from some anti-inflammatory treatments, some antiviral treatments, some including dexamethasone. We've asked and asked and asked, and I'm under an immunologist for pre-existing conditions. I have had no reply to that very question, even though it was asked by my other consultants. So even I, in a position of knowledge, who is already a patient, when one consultant asks another, my immunologist hasn't responded to that question. My respiratory physicians have not responded to me for 6 months. Nobody will even engage with the thought that there might be therapeutic opportunities. We are finding, and we're applying knowledge from other medical conditions. There are simple drugs, such as antihistamines, both H1 and H2 blockers, which can be used to help some of the autonomic effects, which improve people's symptoms hugely in long COVID. People whose heart rates can be controlled by long-standing medications such as beta blockers and other more sophisticated things. But no, we've had to battle and push for this, but we certainly are asking the question, and it has not been answered by anyone. Why can we not have steroids, anti-inflammatories or antivirals such as other people have in hospital? I'm encouraged that on the actor pillar that is being looked into, though.
Well, one thing I can say to you, Claire, is that we will definitely follow up with the people who are involved in the Access to COVID Tools Accelerator.
Thank you.
That's in our list.
Please
Thank you. Hesitate. Anybody who wants to put in observations about long COVID to make them as specific as you like, because this is something that I'm looking into also with a guy called Martin McKee at the London School of Hygiene and Tropical Medicine, who's actually been asked by the World Health Organization to be part of a group of people who are pulling together all the evidence that is available on the existence of long COVID throughout the world.
Okay.
And also trying to use this, I've forgotten what it's called, cover scan approach in order to try to find out just what are the combinations of organ damage associated with COVID so that we get a clearer understanding. And the third thing is that particular interest in this report that some of you will have seen over the last week, that quite often the long COVID damage is in blood vessels, and these blood vessels, because they've got slightly damaged walls, can also then have little clots in them, and that too is not a good feature of the long COVID condition. Claire, you've probably been looking at that issue around.
Absolutely.
Yeah,
very much so, and quite frankly, some serious pathologies, cerebral, blood clots in the vessels in the brain, late pulmonary emboli at 6 or 7 months. This is still an ongoing thing in long COVID patients. Yeah.
So important. We all know. We all must say to ourselves, it's not post-COVID, it's long COVID. There's a huge difference, because for a lot of people after they've had viral illness feel a bit rough. And that's led to the definition of something called post-viral syndrome or some variation thereof. But the point that Robin made, which is a really important one, is that the people with long COVID have not recovered. So it's not post-COVID, it's still the disease going on and on and on. And those...
I'm sorry to interrupt. I wondered if I could just mention at this stage as well, there's a fantastic looking event. I've shared a link in the chat on the 9th and the 10th of October that's being arranged or organised by ISARIC and GLOPID-R, and I've been working with them to be part of a patient collaboration group on that. it looks like a fantastic 2-day event. It's free. It's got speakers and researchers and people living with long COVID from around the world. And the intention is to have an open forum to discuss lots of these topics. And I think it would be it'd be excellent if someone from the World Health Organization wanted to come as well. And I can put you in touch with Gail Carson if you'd be interested in that, David. But I would encourage anyone interested in that to register. And at the moment, Peter Horby is also scheduled to talk. And I think that kind of idea of having a trial similar to the recovery trial, but for long COVID, would be really interesting, and could also give some insights into the underlying mechanisms as to whether or not this is an autoimmune condition or persisting virus, things like that.
Thank you. Hey, Jake, thank you very much indeed. Just, is anybody who wants to comment at all on this anymore? Lewis Thomas. Lewis, if you're in, could you unmute and come in with your comment, please? Lewis.
Yes, of course. Thank you, David. And sorry I haven't got my camera on today. I don't have one to turn on. Thank you so much for sharing your experiences and advocacy on this. Really appreciate it. I work in the NHS in London in the hospital setting and was really interested to understand if you're aware of any work currently being done in relation to how we get this message out to patients and the public when they interact with our healthcare systems in the first point around long COVID. And I know there's not very much information out there at the moment and not any treatments, but something around just, this is what some people have experienced, long COVID is a thing, and this is what you need to look out for. Because when you think of the number of people who've got going to testing sites every day and the people who are being discharged from hospitals as well who've been significantly affected by COVID, it seems nonsensical that we're not providing them with this information, using those crucial interactions to raise the profile of this condition.
So, Claire, please.
Oh, did you want me to answer or do you want to, Robin?
Well, I'll just hop in and say, so I have the good fortune of sitting on the NHS Long COVID Task Force, as does Claire, and we met a couple of days ago. And I must say, I give real credit to the leadership of that, Nikki Kamani and co, who are moving things forward at pace. I don't think there is yet any clear information but there is increasing information. And in fact, just today, they've set up a subgroup to work on that. I think one of the real gaps is any information when people have COVID. In fact, even if you are someone who doesn't go on to have lingering symptoms, I challenge any of you in the UK to find any advice on what to do apart from to stay at home for 10 days.
Yeah.
Phone all your brilliant medical friends around the world and say, help, what do I do? Because really there is no information being routinely provided, which is deeply challenging. And indeed, on the long COVID task force the other day, one of the doctors revealed that he was in the acute phase, and we all tried to send him home and say, please stop and don't work. But there, you know, we need the evidence, but there are some basic home care things that people are not being told to do. And I think from my HIV activism, one of the things I learned back in the 80s and 90s when we used to have fierce debates about testing was testing is a pathway to care. And at the moment, testing is not being used as a pathway to care. It's being used on a population level for prevention. And I think that's really challenging. And I invite all of you to think about what it would mean if we thought about testing as a pathway to care and what happens when you receive a positive diagnosis. But Lewis, I'm happy to follow up one-to-one if useful. That I think there are some things coming forward. There's, is it Your COVID? Help me out here, Claire. There's a couple of resources they've begun.
Your COVID support, there's not much on it at the moment though, really. That was for the post-hospitalised patients and just a website really. If you've got mild problems resulting, there's nothing on that at the moment. Hopefully there will be, but
just put a link. I've just put a link.
Yeah.
Oh, sorry, Claire.
That's fine.
I've just put a link in the chat to, there is an advert that the Department of Health in the UK has released, but I haven't seen it widely shared. And I did notice it was mentioned more yesterday in the Downing Street briefing than it has been previously. But I think, yeah, just wherever we talk about the effects of COVID, I think it needs to be slotted in. Like, so whenever we're talking about why this needs why the ACT Accelerator needs funding, why we need to focus on public health measures, it needs to be to prevent deaths and to prevent morbidity. I think it just needs to become a paired thing.
Yeah.
Thank you. I'm going to try now. We've got 10 minutes, everybody. And there are a number of people who've made comments. If I could just go to people and they could perhaps make their remarks in about a minute each, and I'll remind you when a minute's up, that would be great. Terry Jackson, because not everybody knows where people have come from. If you want to say where you're from, that would be great. Terry Jackson. Terry Jackson may have slipped off.
Yeah.
Terry, thank you. Just a quick comment from you, please.
I just dropped a link into the chat about the uncovered support. Is anybody here that has experience with part of that group?
Gary, we are, all three of us belong to that Facebook group of over 30,000 people. So thank you for sharing the link. There are a couple of others as well, and Claire and Jake belong to the doctors group, which is affiliated or connected. And there's also a research involvement. When I joined the group, I think we were under 1,000. It's growing very, very rapidly, and we don't want any more members, really.
Thank you. Out to go. James, do you want to say anything before you go? Okay, James, thank you. But when you go back to New Zealand, make sure you stay in touch with us and tell us whether this kind of is coming to you in the Southern Hemisphere. Yusuf Gottlieb from Israel. Yusuf, you have a chance to speak now. Yusuf.
Yes, good evening, everyone. It's nice to be back. I'm having a sense of deja vu because the condition, I've been worried about this condition, this post or this ongoing condition of COVID. And it's very reminiscent of a condition that I know very well called pulmonary hypertension, which is a rare disease which has disabling effects. It has a number of forces, and it was really only in the very late 1990s, early 2000s that it was even named. And I think that some of the things that can be learned from pulmonary hypertension and the science that has developed around it is until a condition has a name and is characterized and can be measured in terms of markers, it doesn't exist in medicine. And I think it's really vital to to start, for example, something that's borrowed from cardiovascular disease and is also used in pulmonary hypertension, the 5-minute walk, which could be a very important marker.
Yeah.
For people who have this. So if just to sum up, I think it's vitally important to get metrics. I think it's vitally important to get organized.
Yeah.
It's vitally important to get a patient association going with an executive board consisting of medical professionals and getting a vigorous, multifaceted, integrated approach to this. Thank you.
That's great. And we'll stay close to you, Yusuf, especially if you can share with us any Israeli experiences here too. I'd like to go slightly unusually. I'm going to Chris Shipton. Chris, from Live Illustration. Chris, what were you going to say? Because it was a really nice idea.
Yeah, well, I mean, can you hear me okay? In the business world, we have like a process for creating infographics in a slightly more formal way, where we sort of take people through a kind of really rapid workshop, and it's all done virtually these days. And then that gives us like the kind of prioritized information to make an infographic. And we kind of sort of think about the audience, like what level it should be at and that kind of thing. So I thought, you know, maybe as a kind of side project for live illustration, if anyone from the, you know, nascent long COVID response, you know, wants to have one of those mini workshops, maybe we could come up with a kind of something like more like an illustrated leaflet or something to get the key points across. So I put my email in the chat. So, you know, get in touch and maybe we'll find a moment, because I've got some facilitators and copywriters and people, so we can make something happen.
Brilliant. Thank you very much, Chris. And thank you, as always, for your most amusing, for me at least, pictures. And thank you for this one, which you've just shown. Very, very nice. We give our guests a chance to make a comment just at the end. Henk Bekkerdam, please. You might want to take us to a different place, but just a minute, a quick minute for you to share what you were going to say.
Thanks, David, and very many thanks for Robin, Claire, and Jake. I think this is one of the key essence why COVID is so special, and I think this needs to be documented. We need to have an understanding about the extent of it, because we all know we're sometimes arguing with other people that this is just a flu or this is just this, but the mobility aspect of this long COVID is extremely important. I've got friends who can't walk 1 or 2 stairs up, etc. And I think this is so important. But what we need to get, and I think hopefully through your research, what you're doing is that we need to get percentages, that we say from this is the percentage of people who get long COVID. Yeah. This is an argument what we need to make with policymakers. We have to have an argument to make sure that we take it serious, especially now with the COVID. I see people now relaxing and say, okay, let it all go. They forget about one thing, that's this long COVID. So I hope that with Martin McKee, David, what you're going to do, pull all this evidence together is important. But the same thing, very brief from this one, like the asymptomatic and the pre-symptomatic one. I finally found an article that we know now the percentage of is 20% is asymptomatic. Yeah. These percentages we need also to know from the long COVID. But I also hope that there will be research protocols, and that the research protocol, David, I'm looking at you. What we've done in WHO, we've done some research on elements and like also the vaccines, but why is there not protocols that at a certain moment globally we're going to do protocols to investigate? Because we have to do a lot of learning, and those organs is not one simple organ, especially when it's in vessels. At the end it can be in any organ. So I do think, and I'm very much looking forward to this, I do think that I would like one small comment and links to another thing that I put also on this testing part remains also very important and as an element that we can control it. I put also some things out on the chat, but it was not for today. But thanks again, David. And Robin and Claire and Jake, wonderful.
Thank you, Henk. Henk is ex-WHO country officer, ex-WHO regional officer, has worked in 2 of the biggest countries in the world population-wise, and as a really great friend. When Henk talks, the world listens. Thank you, Henk. And I'm thinking that we'll take up this question of testing and testing strategies sometime in one of the next ones, either on Friday or next Tuesday. Thanks for putting that in. Going to just make one. Jean-Luc Poncelet is here. Jean-Luc and I have worked on a number of things in the past, and he was a senior officer in the Pan American Health Organization until quite recently. We worked on issues in Haiti and elsewhere. Jean-Luc, we haven't seen you on this before, so welcome. Is there any, if you had a minute, is there anything you'd like to say?
Well, David, it's really a pleasure to be with the group. Just arrive a bit on the site. Yeah, I'm fascinated by that conversation, and really would like to make comments in the next one. I just joined this one, a bit on where it was going, but yeah. I think really looking forward to. What I'm fascinated by is to see that COVID is too frequently seen as a health issue, and I think you put that very, very clearly, it is clearly a multi-sectorial, where we have to engage everyone on. I will write you a bit on the side to share a bit some of an article that I'm writing now, so we can further have other conversation later on. Thank you for offering the floor.
Thank you, John Luke. And Magen Mutepfa, if your internet is good enough in Gaborone, did you want to make a quick remark before we close? Magen, lovely to hear you, see you. You have the floor.
Thank you, David. Yeah, thank you, David. I would want to express my thanks to the three speakers. That was very informative. And here in Africa, we are not even talking of long COVID. So it's actually helpful for us. We can now start to envisage what we will be. As you know, so people are not even worried about long COVID. They're just concentrating on it and helpful for us, for we can prepare and maybe look at also new research that can come up so that it can help us deal with all these terrible happenings. I want to wish the three people the very best, and we'll pray for them. Thank you, David.
Oh, thank you, Magen. And Joe Nichols in Nairobi with Miles, I think. Hello, Miles. Does this resonate from the perspective of East Africa?
Yeah, I mean, I think Kenya's experiencing quite a high number of positive cases at the moment, with rates between about 15 and 20%. But the surrounding countries, it's not gone up too much. But no, the focus is, as Magen says, I think it's on people getting sick. It's the mortality rates as well, but not the consequences afterwards for the time being that people are concentrating on.
And what Jake was saying earlier about people who don't have lots of money getting sick is going to be a really, really terrible problem.
Thank you, Joe and Miles, and that's been on my mind as well. I do want to just talk to Rebecca Cantor, and in the Associated Press, and it's been picked up quite widely, there's reports of a fact that WHO headquarters, 2,000 people, has got 65 who've tested positive for COVID. And I've just been talking a little bit to WHO colleagues about it. And it's important that everybody hears what I'm about to say. There is a very, very high incidence of COVID in this part of Switzerland. We are right at the epicenter in terms of incidence per 100,000 of COVID in Switzerland and in Europe. It's a very, very, very intense transmission here. And we would expect just about every school, every institution, every workplace in this area to have some COVID. The WHO, along with the rest of the United Nations here, has not been spared. Now, there are very few people working in WHO at the moment. It's between 5% and 10% of staff going in. And the analysis done by the staff health group is that of these 65, the vast majority got their COVID at home or through social events. They didn't get it at work. But there is suspicion that there is one cluster of at least 5 people who got COVID at the same meeting inside WHO headquarters. And I think what this shows is that this is a really tricky infection to prevent, especially if somebody is secreting a lot of virus. And the current analysis, that's not complete, is that this was what we would call a spreading event, where somebody with a lot of virus managed to infect others. And naturally, there is a great deal of concern about it, just as like there is concern about virus infections occurring in other major centers like the White House and so on. But the current situation is that the majority of the 65 got their COVID at home or outside the WHO, but it looks as though there is one cluster which was inside the building, and this is a source of major concern, and they are looking at how that might have happened. Rebecca, is that aligning with what you've heard, or have you heard something different?
No, yeah, it's what I read. It was all over at least Twitter the past couple of days. But then in the White House, it's very clear no one's wearing masks, and that's where everyone's getting very angry. But Catherine just said that people do have to wear masks inside the WHO. So it's fascinating and ironic at the same time.
A mask is not 100%, and we're having conversations with engineers at the moment, Catherine and I, about whether or not we need to be a bit more precise about masks, and I think we probably do. We'll come back to that. It's 10 past or 8 past. It's just, Chris has shown us his thing, but Twee has not told us who we are and where we're from. Twee, please.
Thank you, David. I'll end the poll now. So just sharing the results. Most people joining from Europe. And as you know, we also hold these same sessions on Friday morning, 8:30 a.m. Central European time. We have a few less people coming then, but if you're around, do join us then. And if you know of people who can join at that time, we have people joining from Australia and New Zealand quite frequently, please do let them know and invite them to join us. I've had some messages saying, people aren't sure if this is just for public health professionals, but everyone is welcome. So just an age range, great to see a good spread across all age groups, and then how everyone's feeling today. One person has selected the lowest emotion, so sorry to hear about that. But on the good side, we have 7 who selected the most positive, with most people feeling optimistic and hopeful. So that's...
Okay, thank you, Twee. There are 3 subjects that I know people would like to hear about, and they're in our list. 1 is testing, 2 is COVID in Africa, the 3rd is vaccine. But I actually think that we should also, thanks to what Gawaha and Sally Smith are writing, also be thinking about lessons from HIV, something that Robin is keen on as well. So I'll try to make certain that you get plenty of warning in advance when we've got a subject session. So we will definitely bring these up. I think that 10 minutes over time is pretty bad, but I think I'm apologizing for that, but I want to, thank Robin Gorna, Clare, Rayner, and Jake Suett from the bottom of my heart and my soul for their absolute bravery for what they're doing. Really important. And the fact that you're doing it whilst you're also feeling rotten and you've got a fluctuating and volatile illness, I think is amazing. We are in your debt and we will be your advocates. I'd like to thank John for stepping in while I was indisposed and just giving everybody an insight to the report, and thank Rebecca and others. There are many actually who've done some really nice social media work on this, and we'll keep you informed of how it goes. And we know that some of you feel that it was a bit dry because the numbers of words was a bit limited, and we'll try to get it more. Thank you, NK, for reviewing it and commenting. That's great, but many others as well. And with that, and thanks and appreciation to the team who are just brilliant, Catherine, Florence, John, of course, William, of course, and then others who I can't tell whether they're on or not, but most importantly, on behalf of all of us, Twee, our brilliant communications chief, thank you all. With that, I'm going to say bye-bye and hope that if I'm lucky, I can see my grandson or daughter. I'm not sure whether they're on. Let's see. Thank you very much, everybody. Thank you.
Thank you. Bye.
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 Bye. Oh, I've got
There's Polly.
Otto is there. Otto and Isaac. Hello to you both. We're all lovely to see you. Very, very, very good. Hello, Isaac. Isaac, who looks like Boris Johnson having had a haircut. Very good.
It's so unfair.
Much prettier.
So unfair. Hi, Polly. Take no notice.
Lovely to see you. Thank you. Very good. Thanks, Polly. Hello, Isaac. There he is. Brilliant. Look at him.